Hello, everyone. My name is Laz Boris, and I'm the president of the Thyroid Foundation of Canada. I'd like to welcome you to our educational webinar. Our guest speaker today is Dr. Jack R. Wall, who will be speaking on mental health and thyroid disease. Dr. Wall, now retired and living in Melbourne, Australia, is the co-founder of the Thyroid Foundation of Canada. He is an honorary professor and adjunct member of the Department of Endocrinology of Macquarie University in Sydney, and honorary professor at Notre Dame University of Australia. As a thyroid specialist, Unity and Brain Endocrine Associations. While he is not a psychiatrist, he has worked closely with Sydney-based specialists in joint clinics where patients with mental health disorders and metabolic disorder combinations were seen together. A question and answer session will follow the presentation. Catherine Keane, our administrator, will be acting as producer for this webinar and managing the technical aspects of Zoom. If you have any technical issues during the webinar, please reach out to Catherine via the chat feature. Anista Primachandran, our director of research, will be looking after the Q&A section and assist us in the chat room. This event will be recorded and made available on our website later this week. A little bit of housekeeping before we begin. Today we are using the webinar functionality of Zoom. This means that you can see and hear the presenter and support team, but your audio and camera are not active and we are not using the raised hand feature. You're able to communicate with other attendees using the chat feature at the bottom of the screen, so please feel free to join in. If you do not wish to see the chat previews displayed at the bottom of your screen during the presentation, please click on the chat button arrow and deselect the Show Chat Previews option. Please use only the Q&A feature located at the bottom of your screen for your questions to the presenter. We will not respond to questions entered via the chat feature or from emails. Please note that our webinars are presented in English. If you wish to have subtitles in French or any other language, please select the CC closed caption option at the bottom of your screen and choose your preferred speaking language. At this point, we are ready to begin with Dr. Wall's presentation. Dr. Wall?
Yes. But I still have the join the new meeting. Do I put cancel now for that, do I?
No, you're ready to go.
All right. Thank you, Laz. Thank you very much for the introduction. And I guess when you haven't Zoomed and you're 80 and a half, life becomes complex. It's probably the most complex thing I've ever done, except getting married. I'm not a psychiatrist. I consider myself to be a basic scientist and a thyroid specialist. Thyroid specialist, I define as an endocrinologist with a major interest in thyroid disease who has his own ultrasound machine. And I have that behind me, but I'm not going to swing around, otherwise my phone will end up on the floor. Believe me, to be a thyroid specialist, you need to have an ultrasound machine and do a few thousand and be prepared to do biopsies. To summarize at the beginning, my advice, and this is what I've been told by experts about the problem of thyroid disease, in mental health disease, along with thyroid problems, is don't worry, boost your mood, work out, sweat, feel good, and of course, be happy. And watch the hockey when Edmonton are playing. So what mental health disorders are we talking about? There really is only one of interest or of importance, I think, and that is depression. Of course, many other mental health disorders, anxiety, bipolar disease. The big fashionable one these days is autism spectrum disorder, which most people have if they're famous and make electric cars. So I'm going to talk mainly about depression in the context of thyroid disease, remembering that I'm not a psychiatrist. Thyroid cancer, thyroid nodules, are important problems generally, but not in respect to the mental health disorders. Post-traumatic stress disorder, common problem in this country. I live in Melbourne, which used to, alternating with Vancouver, be the world's most livable city. Then it became, during COVID, the world's most lockdown city. Where I live, and we were allowed to walk 5 kilometers from home, depending on when I leave my front door, which way I turn. If I go left, I end up in Port Phillip Bay, which is about a third the size of Lake Ontario. If I go in the other direction with 2 or 3 turns, I end up in the Southern Ocean. So unless you can walk on water around here, you can't do your 5 kilometer walk. We all survive that sort of. Mental health disease is a problem in the community everywhere, not just in Australia where I live now. And there was a huge increase in prevalence before, during, and after COVID. We'll come back to that. I told myself I wouldn't mention the war and I wouldn't mention COVID, and I've already mentioned COVID 4 or 5 times, but it's the most important thing that's happened to us all, probably ever. So what thyroid disease is, again, there really is only one of major interest in the context of mental health disease, that is Graves' disease. Other disorders, toxic nodular goiter is hypothyroidism without the autoimmunity abnormalities. It's much less common and much less important. And transient forms of thyroid disease, subacute thyroiditis, silent thyroiditis, postpartum thyroiditis are all transient autoimmune problems. Subacute thyroiditis is due to various viruses, no doubt COVID as well. I've looked at 6 times. Someone can count how many times I mentioned this disorder. Thyroid disease is about 8 times more common in women than men. I can't see anyone. I see myself, which is nice. I last gave a talk to the Thyroid Foundation of Canada in Montreal a long time ago, on probably around the same time, on a Sunday at around 7 p.m. And I noticed that everyone in the room was a woman, a lady with prematurely grey hair. And I thought that is because these people get thyroid disease, or the men are all home watching the hockey. I'm glad it's not the Vancouver-Dallas game today, so I can forget that and then carry on tomorrow. I will mention a patient who is, I think, representative of the problems of COVID, thyroid disease, mental health problems, anxiety, and ophthalmopathy. 38-year-old lady who lives on the north coast of New South Wales, where most of the world's best beaches are situated. She has mild eye disease, and therefore radioactive iodine was a problem. We now know that radioactive iodine can cause the eye disease, even in people without any eye signs, when they have their radioactive iodine. So she was concerned about that. Her mother called me from Sydney because when she had her first COVID vaccine, her Graves' disease became much worse. And so I was involved. We were doing telehealth, and I'm no longer working. I'm retired, so I don't know what has happened to her, but I don't think she's back surfing yet. With her second vaccine, her first vaccine made Graves' disease worse. Then she had a second AstraZeneca vaccine, which probably was a mistake, and she developed shoulder-hand bursitis syndrome that can occur in some people. Meantime, she developed allergy to carbimazole, the anti-thyroid medication that we tend to use in this country. And finally, of course, she caught COVID despite the vaccinations. And she said it was like being hit by a big London bus. And of interest is, during that time when she had COVID, she forgot to take her thyroxine. Oh, that's bad. Eventually, she remembered, she recovered, and she's not bad at the moment. So Graves' disease is the main thyroid disorder that's relevant to this conversation about mental health associations. Mental health disorders and thyroid diseases are both very common. So, of course, sometimes they will occur together. It doesn't mean one causes the other or even makes the other worse. The combination is bad. We see mental health disorders and transient problems, sometimes even psychosis. I remember I'm going to talk about relevant patients I've seen over the last 50 years, which makes me a bit scared to think how old I am. But normally I walk 15 kilometers a day, so bear with me. The things we've seen in respect to mental health changes in someone with Graves' disease range from the ridiculous to the tragic. Patient I saw at what they call the DO, Hotel Dieu, l'Hôpital Hotel Dieu, Kingston, where I worked, 78, a man walking around the entry, being chased by a nurse waving his arms around his head. So, that can be thought of as a little bit funny. He was my patient. It turns out I treated him, he recovered, and he lost his wings, through to tragic situation of a patient who suicided, not my patient. I was involved in a management discussion about what caused this problem. The story, if it happens in the US, who's to blame? If it happens in Canada, how do we fix it? If it happens in Australia, it's who do we sue? This lady was very depressed, had Graves' disease, and she was concerned about radioactive iodine treatment. We know that it's controversial now. Should we use it? We probably shouldn't. It can cause the ophthalmopathy even in people without eye signs at the beginning. So she, for some reason, she decided that this is all too much, and tragically she suicided, which of course is not a good side effect of this combination, Graves' disease and depression. We'll come back to a few things here, but it's most important that the family is involved, best friends, partners are involved with people who have Graves' disease. It's too difficult for the general endocrinologist, who's not really a thyroid specialist, and it's too much. It's also very difficult for family members. I would say patients with Graves' disease coming to the endocrinologist should bring their significant other, who then understands what is going on. Many people will say, in other words, the ladies, that their husband doesn't understand the Graves' disease, the symptoms, and sometimes people separate because of this. So it's a problem. This combination is a problem for the whole family. And why did this girl finally decide that she was not going to cope with radioactive iodine or the ongoing symptoms? We don't know. And people like to look into who did what. Was it the endocrinologist's fault? Do we blame the GP, blame the family for missing the fact that their 28-year-old relative was very, very depressed? Or do we blame the patient, or do we blame everyone? Do we blame the health service? There's no easy answer. But it must be seen, it must be treated as quickly as possible, because it can occasionally lead to this tragic outcome. Anxiety is much less common, much less, I would say, less severe, less important. We can all be anxious if the stress is bad enough. But anxiety, of course, also is a symptom of the Graves' hypothyroidism itself. So the disease has some mental health manifestations: irritability, anger, anxiety, can't sleep, rapid heartbeat, sweatiness, so on. So again, it's very important that we identify the association with depression very early, and particularly to be beware of delusions, hallucinations, and severe depression, and other psychotic changes. We don't see this combination often. In fact, it's very rare. But as I said, common diseases will occur together occasionally. And the depression is by far the most important of the mental health disorders because of its additional effects on thyroid function, because of the brain, endocrine, thyroid, autoimmunity links. So Graves' disease is really the one mental health disorder that is relevant to this conversation today. Other mental health disorders occur that probably have nothing much to do with thyroid disease itself, but generally speaking, both are worse if you have them together. The Graves' disease becomes worse, and the hypothyroidism, the mental health manifestations also become worse. So it can be a very difficult clinical situation to manage correctly. On the other hand, Hashimoto's thyroiditis, which leads to hypothyroidism, although much more common, the association with mental health disorders, much less important in that they are less common. People with Hashimoto's hypothyroidism tend to be flat, sleepy, constipated. They're too unhappy, too tired to be worried about whether they are depressed or anxious. Of course, they can be those things as well, but the combination is uncommon and certainly not specific. Thing to note about Hashimoto's disease is that many patients will have a goiter. I see goiters all over the place. I see them in anyone who's a newsreader, and I've watched one lady have her goiter up and down over a several-year period, and she still has the goiter and still speaks in Australian-type English. So the information is to be noted, and patients can treat themselves with Panadol, paracetamol, I'm not sure, Tylenol, that's what it's called. Quick other question about this disease is when you start thyroxine because you want to nip in the bud any mental health problems, depression, anxiety. I noticed on our news service last week, the lady with big goiter said there have been many more thyroid tests carried out for symptoms of thyroid disorder. In fact, the number of tests performed in this country has exploded. So I'm not sure what an exploding test looks like, but it's common, which happened to occur in Thyroid Awareness Month. And this is despite the fact that I retired, because every time I retire or move from Montreal, from Kingston, even from Pittsburgh, everyone said, well, we don't have a thyroid specialist anymore. What do we do now? And they all ring me up, call me, email me for me to give them the names. So despite the lack of me, the testing that's carried out is increased greatly. There is a condition badly named called myxedema madness, but I don't know what else you can call it. That is of historical interest. End-stage hypothyroidism can lead to hypothermia, from which the patient can die. A coma or pre-coma or coma, and they need to be admitted to hospital, treated with intravenous parenteral thyroid hormone fluids, steroids. They usually recover, but it is rather dramatic and reminds me of cases I know about. I've only seen this in one patient in Montreal, a lady from India who was brought out by her family, but at some point in time they said, well, we don't want to look after you anymore. You can go and live in the streets of Montreal, which is pretty good in the summer, but not very good when it's minus 25. Unless you can find a nearby Gretzky Hotel and watch some hockey. So this patient was managed, was treated, and eventually did well. And hopefully she's not living in Montreal streets at the moment. And the last patient I saw in Canada, in Halifax, after 18 years working there and 6 in Pittsburgh, had hypothyroidism. He also happened to be Indian. I'm not picking on the Indians. I love their cricket. But he was given thyroxine by me and sent away. And when he came back, I explained, this is you're like my last patient. Isn't this terrific? After all these years, I see you, give you another prescription, and then I disappear back to Australia. And he said he was angry at me, and I didn't really know why. And he said, the treatment made me very angry. I became aggressive, and I was sacked from work. And I thought, well, it's a good thing I'm going back to Australia. Otherwise, he might go to a lawyer. Of course, you have to be careful about treating hypothyroid patients with too much too soon of thyroxine. We know from earlier webinars that there now is a discussion around whether patients also need some slow-release T3, and we don't know. We're a long way from being able to have a definite specific guidelines. So be careful, start slowly. We start slowly to avoid this effect, because the brain has been used to living with no thyroid hormone or very little for many, many years. And if you suddenly fill the patient up with thyroxine, you can cause either myxedema, madness, that does not excuse the name, but I don't know what else we can call it, or just end-stage hypothyroidism with the usual treatment with thyroxine. So beware too much too soon. This poor guy was really angry at me, and I was trying to tell him this is a good day because I'm leaving the country. Not that that was a good thing, but it was of some relevance that you're my last patient. And he was the only one I ever saw who probably thought about whether I can report this Australian guy. There is a condition called Hashimoto encephalitis, which is of interest. Patients usually come into hospital because they're drowsy, they are confused, hallucinating perhaps, headaches, wondering what's going on. They come to hospital and they have a lot of tests done. T4, T3 levels are usually normal, but their thyroid antibody levels are very high. And this tells us that the antibodies or associated antibodies against brain cells, neurons, are also present, causing damage to the brain. And we know that this is a very rare, very interesting condition because of what it does to patients, but more so because they recover very rapidly when treated with steroids. I've seen a couple of these patients that will recognize every time someone sees such a patient, they like to write a paper about them. There were lots of doctors around on this particular day, including the ID guy. I think he was ready to do a brain biopsy, so we quickly got rid of him, gave her steroids, and she recovered rapidly, then went home. Confusion, coma, normal TSH-T4, high thyroid antibodies level. So now treatment of the problem. You probably have the impression, which is not really quite accurate, that mental health disorders don't happen in people with thyroid disease, and if they do, generally it's manageable and they're okay. Most of that I've just said is true, but they can lead to tragic results occasionally. The big thing is for patients to rely on the doctors and their families to look after them, to monitor them, to make sure they're okay. When something goes wrong with yourself, and finally you find for the first time for a long time your kids call you and ask you how you're doing, and you get a bit, you think, why are you I'm all right, don't keep calling me. But in terms, if you're married to someone with new onset Graves' disease and you don't understand that, and you don't understand the symptoms, and then she's depressed and she's anxious, or both, you really need to be careful to be helpful, to help the patient through this situation. So involve the family, even close friends. And I think patients with Graves' disease should all come along with someone. It's a significant other who could be a best friend or a partner, a child, who are as smart as my grandchildren. That'd be very helpful. We know that the thyroid hormones have non-specific effects on the nervous system, in particular on aspects of the brain. And I think this is probably why there is the association between hyperthyroidism and mental health disorders, anxiety, depression specifically, but not so much with hypothyroidism, which doesn't have the same effect on the brain. And that we expect mental health disorder to be worse because of the effects of thyroid hormone on the brain, liver, and other organs. So who should treat people with this combination? How should they be treated? Who should be involved? GP needs to be around. I'm not going to say naughty things about the Canadian health system, but I have a lot of my friends still there, and they tell me they don't have GPs, and they need to see a specialist. If they're in Kingston, need a specialist, they're sent off to Toronto. And the guy there says, you have the wrong referral. I can't see you for another year. So I didn't say that. Who to treat? GP, yes, of course. Now, psychologists really need to be involved as soon as onset of depression or anxiety is noted. These days, there is a shift away from medication to other ways of treating people, including meditation, mindfulness, yoga. I found if you're going to become a yoga enthusiast long term, you must make sure you're not an 80-year-old male with a bad back, because you can't even get on the floor. But in theory, it's good exercise. As I said at the beginning, much of it is about mental health, is about controlling stress in this very stressful world. And the advice again is don't worry, boost your mood, work out, sweat a lot, feel good, and be happy, just like in that song. Easy to say that, but not so easy if you happen to have mental health disorder and the nasty symptoms that can go along with that. But involving family and friends to help, an endocrinologist. The endocrinologist should really be the person to monitor and manage what is going on, so-called quarterback the whole situation, and recognize the onset of depression, which is very important. Now, there are a couple of things to say towards the end here. How else should we manage people now and in the future? Behavioral therapy, I talked about. Artificial intelligence is the big thing here. So it may be that people are given their own little robot who helps them monitor, identify, and treat the symptoms of the mental health disorder, which can be devastating in a patient with Graves' disease, about to have radioactive iodine for their ophthalmopathy, who don't understand why they have what they have, why they have the side effects, and what is happening with their eyes. For quite a long time, I worked with a psychiatrist in Sydney. Most of my patients were referred by the psychiatrist who said it was important to identify metabolic problems, diabetes, and thyroid disease. So a lot of my patients came from him. I had my ultrasound machine, and I could even, in a psychiatrist's office, do thyroid biopsies. So a combination of therapy with, say, a psychiatrist is very good. He is treating the psychiatric problems, and the endocrinologist is helping him manage this by identifying and treating the mental health, the thyroid condition. And role of psychologists. I think psychologists can be very helpful. Things like teaching you how you should sleep, non-medication treatment of patients, yoga. I mentioned you can go on to yoga anytime if you can get on the floor and do the things they tell you to do. But it's all good. I try and meditate daily, usually in the evening or after late. Here we have the hockey in the morning, so I watch the game. And if Edmonton wins, I'm happy. And if they lose, I'm unhappy. And then I do my meditation to get me back to the happy state. Exercise. And I think, let me say, attitudes and the future and what it really means. We need better attitudes to people with mental health disease. It's easier if you're a champion sportsman and it all gets too tough and you jump off the Westgate Bridge, break a few bones. People are aware quite often Australian rules footballers disappear. They're not playing for personal reasons, which always means they're depressed. I mentioned the bridge. We had a man here, South Sudanese, who became the figurehead for the whole community, everyone in his community. And there is a big community in Melbourne of South Sudanese, and they wanted his help and probably money and fame, and it got too much for him and said, I can't deal with this, and he jumped off the Westgate Bridge. He didn't die, spent a year recovering mentally and physically, and then when he came back onto the AFL scene, he played a game and everyone was very happy. And one of the commentators talked to him about this and was crying and saying how proud he was of this guy for getting back and playing again. And he said, my father and brother suicided, and that's perhaps why I'm crying. So it's become really important in our community. And I think any associated thyroid disease is really incidental. It doesn't happen often. It makes things worse if it does, but it's manageable. But the mental health disorder is the key. How do I know? I'm not saying. So I think I've said what I wanted to say, and there'll be questions. Just to go over the main points again, though, combination of thyroid disease and mental health problems is really Graves' disease. A little bit about Hashimoto's hypothyroidism, and the thyroid and the mental health disorders are usually depression or anxiety. I'm getting signals which said I should probably stop talking. So I will stop talking. Hope you're not thinking that I'm underestimating the importance of the thyroid disease in people, for example, during this very difficult period of COVID, before, during, and after. A lot of people became, I know almost said everyone, a lot of people develop mental health problems. You're locked down for months. You can't go anywhere unless you can swim well. And my phone says low battery, which is nuts. So thank you.
Thank you, Dr. Wall, for a very interesting presentation. Yes, we're going to open it up, the webinar, to questions from the attendees. I noticed we're getting a lot of questions in the chat. Please use the Q&A, not the chat. We'll make an exception every now and then to make sure we get everybody's question answered. So Hanista will proceed with the questions. Now, if you have more questions, please put them through the Q&A section at the bottom. Hanista?
If I disappear, I'm going to have to rush out, get charge up again. I thought my phone was fully charged when I started chatting. I guess I talked too much. Sorry, lads. I understand. Thank you.
Thank you, Dr. Wall. I'll get started with the first question. So is there a relationship between metabolic syndrome and Hashimoto's disease?
Metabolic syndrome, syndrome X, polycystic ovary syndrome, diabetes, that combination, you mean? I'm not sure what your polycystic ovary syndrome is common. Hashimoto's, sort of question someone asked if they have one or other or both. I don't think there's a particular association with Hashimoto. Hashimoto's is a classical autoimmune disorder, the most classical, and it can be associated with brain autoimmunity, encephalitis. I don't think we see people, both, again, common conditions, people with metabolic problems, diabetes, hypercholesterolemia, etc. It's a common problem, and many of these people are women, and many of them have thyroid autoimmunity, including Hashimoto. But I don't think there's a specific relationship. We see it a lot, but common things occur commonly. All right.
Thank you. And then there was one in the chat to me. So does thyroid-related mental health issues look different between men and women?
Between what and what?
Between men and women?
That's a very good question. Both are very common in men and women. If you're looking at footballers, very common amongst footballers when it all gets too difficult. Now, well, I think if they have Graves' disease as well, or other thyroid disorders, the manifestations are different. thyroid disease is much more common in women than men, 1/10 as common in men. And of course, women will have other specific women-related symptoms such as amenorrhea, other menstrual problems. Some women I know at the beginning of the Thyroid Foundation, when this was developed way back, would be accused by people, sometimes by even a GP, who says, you know, it's due, your breasts are too big, or you're too tired, or you don't sleep enough, you're depressed, that's why you have hypothyroidism. Treat those things and you'll be fine. But really, it's more about a woman is different from a man, and explanation needs to be a bit different. I advise both to bring along their most significant other, so they understand what is really going on, for it to be helpful. All right.
Thank you. The next question asks, I think you made a reference that radioiodine treatment is not recommended any longer. Did I hear that correctly? Is this for all reasons radioiodine is used?
Yeah, it has become very controversial. I've been involved in 2 cases so far where the endocrinologist did not warn the patient that she might, usually it's a she, develop ophthalmopathy after radioactive iodine, and therefore sued. The doctors were sued, and I got involved as an expert witness, which is a tricky situation. Typically, it's thought that, well, people, if you don't have eye disease when you have your radioactive iodine treatment, you won't have a problem. It's very unusual to develop new disease, de novo disease. But they can, particularly female smokers, females, because they're more likely to get ophthalmopathy, and smokers, because that's a major risk factor for thyroid eye disease, as we know. So the main guidelines from the American Thyroid Association, the ACE, and even the European guys who have this sexy name, U-Go-Go. It sounds like a dance you do in Brazil, but it's actually a way of looking at developing guidelines. And I've just actually writing a paper right now, and I'm saying to everyone should warn the patient. I don't like writing in a paper just in case someone sues you, but that's really what it amounts to. Australia has become a very sue-conscious society. We just like the Americans. I hope there are no Americans listening to me. But it's not in any recommendation. The problem is if you tell people you can't have radioactive iodine, then you're losing a very good treatment for the hypothyroidism. So a lot of people now will continue to take anti-thyroid medication just because they're afraid. Like the tragic case of the young lady I mentioned, she was really bothered by radioactive iodine, to the point that it made her depression worse with the awful outcome. But if the patient has I think it's important patients are referred to an ophthalmologist who specializes in this condition. They can say and state in a letter they send you that the patient had no eye signs. I hate to think we're in a position where we actually do this because in case someone wants to sue us. So no one will say you shouldn't have radioactive iodine if you don't have any eye signs, but we've seen more cases, and then you develop an epidemic of it where everyone claims their eye disease got worse and they think they can make some money out of it because everyone's inflated in this country. No one has any money. Coffee, $10, about that. That's a bad situation that's getting worse, and people are looking for ways to get through it. I'm not saying that's why everyone sues their endocrinologist, but I would certainly warn every patient, write it in the GP's letter and write it in the files. And looking back, I don't think anyone has ever had worsening of eye disease if they didn't have symptoms. If they do have eye signs, typically the eye disease gets worse after radioactive iodine. We see that all the time. Very common, and it's a problem. But it's the big problem, of course, yes, as you mentioned, if you don't have eye signs, should you be given radioactive iodine? Yes is the answer, but be careful. Document it and have an ophthalmologist assess the patient before you do so. Okay.
Thank you. The next question asks, is there anything that can be done to reduce the thyroid antibodies in Hashimoto's and preserve the thyroid?
I knew someone would ask me this question. There are a couple of things, vitamins, and I'll probably think of it when the battery runs out here. I've used these sorts of things on a couple of occasions, but you really don't want to. If they have Hashimoto's, they will develop someday in the future hypothyroidism, and you warn the patients and tell them to have testing every now and again. Sometimes they do that, sometimes they disappear. So no, not whereby it's useful and you would do it on a large scale. There have been studies of the name. I forgot the name. Now, I was going to wear my lumberjack shirt today, and I forgot that. I couldn't sleep last night. I thought, what the heck is that shirt called? Just to, in behalf of Edmonton Oilers. So I'm not wearing it. So I'm short-term memory. And that does happen when you have migraines, and I get migraines, which so do 20% of all women on the planet. So I can't remember the name. There is a medication that has been used, but either you don't treat or you wait until TSH is a certain level with or without symptom, then you treat with thyroxine 30 minutes before breakfast. Next question.
Thank you. Is hypothyroidism a risk factor for the development of Alzheimer's disease?
There are a lot of risk factors for Alzheimer's, mainly that you get old and you have a family history of it and you don't look after yourself. No, I don't. There really is no. Again, there's no specific relationship. You might think it should do if a thyroid problem can affect the brain. It's short-term, non-specific effect on the brain. Long-term, no. I'm just thinking of my ex-father-in-law who developed this big problem. A lot of people worry about Alzheimer's these days, but there's no close link with thyroid disease. All right.
Thank you. Notably, many mental health drugs, lithium or antipsychotics, have detrimental effects on thyroid and immune systems. Why is the mental health community so out of touch with the research?
There are always new drugs, aren't there? Again, I'm not a psychiatrist. I work with a psychiatrist. He also happens to treat my migraines. So there will be always new medications. Some of them have horrendous side effects. So psychiatrists are scared of that. And behavioral therapy, meditation, mindfulness, and so on are also helpful. That's why psychologists are useful. I don't know whether the psychiatrists are out of touch with the management of depression. And that's what they do all the time. They treat depression and sometimes anxiety. And every patient is different and every patient is difficult. I think it's attitudes of everyone, not just the psychiatrists, but politicians, huge interest in this country to raise funds for mental health management. Because as I mentioned earlier, when it's someone famous and they don't play in the grand final, which is like the Super Bowl, because of personal issues, they're depressed, or they jump off the Westgate Bridge, they're really depressed. And it's common amongst sports people, and more people are recognizing that. So, but there are still the attitudes of mental health disorders. What is it? Should you be ashamed of it? Why don't people talk about it? Why don't people really go about avoiding that? But I think it's really a community problem. There's not enough support, not enough awareness. COVID helped a lot so many people developed depression, other issues during COVID, particularly in Melbourne, the world's most lockdown city, head of Buenos Aires, due to COVID and the lockdown in particular. So things are happening slowly. I don't know about Canada at the moment, whether it's any better, different. There's a big problem. I think it's a major problem in mental health management is who treats the patient. Should they be trying new medications or not? Generally, and such a common and important problem that a lot of the medication they use will have issues. I don't know, in Canada, actually I'm in a position here where it's a little bit difficult, where psychiatrists not readily available for one thing. If a patient was to see a GP, they'd be told, well, we used to be able to pick up the phone and call someone. Now we can't do that. Management is not good, but I don't think it's good anywhere. Universities, departments of medicine, for example, deans say, well, we really would like to have a clinic to treat people with these issues. Is that a problem? They're difficult and they're common, and they don't. We will one day, and people. All right, you with me?
Yes. Thank you.
I'm still here.
Yes. So I'll move on to the next question. So this attendee's Graves has returned for the third time, and they were given two choices, RAI, which I believe is radioactive iodine, or surgery.
Yes.
What are the pros and cons for each?
For the hypothyroidism, it's a magic bullet. It's been said that radioactive iodine is the best treatment for any disease. All it does is go to your thyroid, burn it out. But it does, in fact, that process can make the eye inflammation worse. Antibodies and lymphocytes from the thyroid travel to the eyes and classically make it worse after radioactive iodine treatment. Radioactive iodine treatment then really has just burnt it out. The patient becomes hypothyroid, but that's what you want anyway. You don't want it to recur or to be residual, so you expect to burn it out and treat with thyroxine, and they're on that for the rest of their lives. Depending on where you live, there's a reluctance in this country to treat with radioactive iodine. Studies have been done comparing what would you do, American endocrinologists, New Zealand, Australian, and other, for this condition, this patient. They describe the patient and then give you the choice. 11% of Australian endocrinologists would use radioactive iodine as the first choice, ahead of medication or surgery. In the US, it's 70%, cost effective, money. So gives us more money to send off to the people we want to keep from being killed. I'm having one of those days. It's so cold here. Radioactive iodine, of course, there are usually problems. Again, patient becomes hypothyroid, but you can treat that with thyroxine easily, but it can have recurrent damage to the recurrent laryngeal nerve, swelling, neck swelling, technical issues. You need a very good surgeon. We had here a very good surgeon. They do well, but it's not easy to treat that. And in some countries, in the study, 11% of Australians endocrinologists would treat the patient with radioactive iodine, 70% of Americans, and 30% of New Zealand endocrinologists, which, New Zealand is a country for extreme sports. They jump off bridges, but they're attached when they jump off, and you should see them play rugby. So, they'll try things. It reflects, I think, the attitudes of the communities, the people, which is sort of interesting. In Asia, where they've had bombs dropped on them, everyone is afraid of radiation per se, regardless of what sort of radiation. They tend not. So I think that the tendency is to treat long-term with antithyroid medication because you won't have side effects. You can have an allergy in 1 in 1,000 people. But in the long term, it's probably the safest. But we shouldn't exclude radioactive iodine, the famous magic bullet. And there are still people who would say, surgeons will, you see a surgeon, the surgeon will say, well, we'll operate and take out your thyroid, we cure the problem, and that may prevent the eye disease. So the case they make always is, well, it prevents the eye disease, doesn't make it worse. But the two forms have their side effects, and tablets tend not to. So every patient is a confrontation, is a new patient, particularly if they come along with their significant other, and you need to explain why the choice. But it's not always easy. Even everyone is different. Okay.
Thank you. We have two more questions. So here in Canada for thyroid issues, they only check 2 hormones on the blood panel and ultrasound. If everything is normal, family doctors do not give you a referral to endocrinologists. They'll only give a referral if the situation is bad and you need an operation. What other hormones and tests can you suggest to diagnose Hashimoto's and other thyroid issues?
A medication I mentioned, selenium, I forgot that, along with my lumberjack shirt. Selenium has been used to prevent Hashimoto's, but you're sort of partly treating the autoimmunity. So you said here, the question is about surgeons, not radioactive iodine. What tests do you do?
What other hormones and tests can you suggest to diagnose Hashimoto's?
Occasionally, accidentally, you do a biopsy and you get some Hashimoto's tissue, and it's obvious from the histology. The gland is full of lymphocytes. The goiter is characteristic. Even in the poor newsreaders, I see it. It'll watch it over a period of time, and then she has a biopsy and it disappears and it comes back again, and so on. So, but that's not a way of diagnosing it. You don't do a biopsy. TSH, T4, the thyroid antibodies. Really, these are very specific, those tests. I tend to test for other autoimmune disorders. Does the patient have celiac disease, for example? Any other autoimmune problems, type 1 diabetes sometimes, other anemias. I just do that because you know there are associations with these disorders. But it's really about the TSH. There is a range, and that's a bit controversial. Is the upper limit? Can you have it? And it doesn't mean that this is hypothyroidism. I don't think it's usually a problem to make the diagnosis. It just ironically, way back when the Thyroid Foundation was beginning, concern was that, again, I'm not trying to criticize GPs, but that patients weren't always tested. The tests are specific and accurate. You do a TSH, the number you get is what it really is. So increasing TSH over level 4, 5, the higher, the more likely, up to in the hundreds, and T3 and T4 are low. But these tests work well for most people. I can't think of any other. The antibodies would relate to other autoimmune disorders, like the common ones, celiac disease, rheumatoid arthritis, lupus, and a whole bunch of others. But nothing more for Hashimoto's. And so it has always been difficult. Patients feel unwell, they read the books and the journals, and they're told, they know that they can have bad symptoms. They have all the symptoms, you tick them all off. But then none of the symptoms are specific, and it does require testing with TSH, T4, T3. I was told maybe in this country that pathologists don't like to do T3. They do a TSH1 test, really is a screening test. If that's abnormal, then you move on and do other things. But they were not paid to measure T3, for example, which is not a good way to manage stuff. But that's what happens. Trying to think. I'm on my feet because I'm plugging in my phone now, charging it up, so it doesn't disappear. And selenium is the only medication I know of that can be used to prevent Hashimoto's. But the argument there is, why, you can't really prevent it long term. You will become, by definition, hypothyroid, and when that happens, TSH is high, and then you treat, and then you get rid of the condition, and you stay on it for the rest of your life, taking before breakfast. I can't think of any other tests for the Hashimoto's itself. So I guess there are people who don't like to be told that the tests are normal. They have all the symptoms, and why don't you treat me? That has always been an issue. But the criteria are very specific, and the tests are sensitive. And as I say, if you have a level that's high, by definition, you are hypothyroid. Can occasionally be temporary in young people, in teenagers, but typically not. If you have it, it's progressive, and it's easily treated. I think if you pick a disease, we'd all pick Hashimoto's if we were told, well, you can have one disease. That's the one most people would choose, because once it's diagnosed, it's treatable. They get patients recover. All right.
Thank you. So last question. This attendee describes having a hard time remembering events and focusing on writing projects. And their question is whether there's a link between hyperthyroidism and memory.
I'm trying to think of a cheeky answer, because everyone's memory goes when you're 50, they say. And if I get certain migraines common as where you lose short-term memory. It's part of the migraine. You can imagine that. You get a bit slurry, and eventually it sort of goes, which is not nice. So the answer is that my short-term memory for the question is gone. That for irony. Just say again quickly, please, what the concern was.
So it seems that this attendee might be struggling with brain fog, so remembering events and focusing on work. And they're asking if there's a link between hyperthyroidism and memory.
So this patient is a member of the audience, probably a doctor. And short-term memory can be normal. It can be due to side effect of beta blockers. It can be due to some forms of that basic brain migraines, for which the treatment these days is Botox. It's transient and it's part of that syndrome, and it gets better, you hope. Just getting older, metabolic things, Alzheimer's itself. Yeah. Brain fog. I'm trying to help this person. They say when you have a problem, you don't go to the specialist, you go to a doctor with the disease, because they know much more, because they have it, and they know every medication that exists, and some that don't. Brain fog, it's a real thing, brain fog, but there are a lot of causes for it. And this person had or has hyperthyroidism, more likely with hypothyroidism. It's more typical. Hyperthyroidism, you have a lot of other symptoms that are of concern, probably a bit more concern, maybe without brain fog is not nice. Memory, short-term memory loss. When you walk around where I live, everyone here is my age or older, and we'll have brain fog. We talk about it, and we ask each other, do we have, well, they ask me mainly, is this Alzheimer's, or is it normal to lose your memory? I told them I hope it's normal. I'm not sure that answer is very helpful, but I can't think of any other comment to make about what is brain fog, for example. So.
Great. So is that the last one?
Yeah, that's all for our Q&A.
Thank you very much, Anista, for reading out all the questions.
Yes, thank you.
I'd like to thank Dr. Wall for giving us his presentation on mental health and thyroid disease. I would also like to thank our webinar team for making this educational event a success. I'd like to mention that if you have some spare time and would like to volunteer to help others with thyroid disease virtually from home, please call us on our helpline at 1-800-267-8822 or email us at info@thyroid.ca. You can also assist us by becoming a member or making a donation by visiting our website at thyroid.ca. As you exit the session, please take a moment to complete our short survey. You will also have an opportunity to enter your comments. This will help us improve our future webinars. All of us at the Thyroid Foundation of Canada wish you and your families a great summer. Thank you very much, everyone. Thank you very much, Dr. Wall.